And most of you would remember reading this in the BMJ in 1898. Of all the lessons which were hammered into me during my hospital career, none is more persistently driven home than the fact that it is extremely dangerous to administer morphine in kidney disease. It's usually well tolerated in liver impairment, although the half-life is prolonged and it should be given less frequently, perhaps. But we, like many palliative care units for patients who've got end of life, we actually do an end of life audit at present looking at palliative sedation therapy. One of the byproducts of that is I'm actually seeing how many of our patients actually end up on syringe drivers before they die. Now, I haven't looked at the data yet, but the impression that I get is that it's fairly high, over 90%. So if you come into Redcliffe Palliative Care and you die, you will have probably died on a syringe driver more often than not. So then that doesn't apply because they're getting the drug continuously. I think there's just one slide on heroin, which is diacetyl morphine. It's still used in the UK. It's a prodrug. It's well absorbed, and that was the issue with it, because you can make a much higher concentration than you can of morphine sulfate. But we actually have morphine tartrate, and morphine tartrate you can get in a concentration of 80 milligrams per mil, or 120 in 1.5 mil ampule. We don't tend to. We used to use a fair bit of morphine tartrate, but now we'd probably use hydromorphone instead. It's lipophilic, crosses the blood-brain barrier more readily than morphine. Parenterally, it's said to be twice as potent as morphine. Orally, the two opioids are almost equally potent, because morphine doesn't have good bioavailability. People say, oh, well, morphine's not absorbed. That's not true. Morphine is well absorbed. It's just that its bioavailability is poor. Duration of analgesia, a few hours. Oral morphine, we all prescribe broaden, so it's available at different concentrations. And then there's immediate release. Actually, I don't know whether Anamorph is still on the market. I'm not sure whether it is. We tend to use Sevrodol nowadays. And then you've got sustained release preparations. So MS Contin, which came on the market in 1991. It had been available overseas for a decade prior to that. And then we've had Capanol, was released a few years after that, and MS Mono. And then just remember that MS Contin is available as a sachet, which I always find quite interesting. You sort of mix up the solution, but it's a sustained release solution. So once again, I think that's got pretty much a niche market. But certainly if you've got a patient who's running with a peg tube and using that well, then it's an option rather than putting up a syringe driver. Parenterally, we use morphine via the subcut route through an indwelling catheter. So when patients are admitted to our unit anyway, they get one of the safety enema ports put in just subcutaneously. So whereas, once again, a decade or so ago, we'd use butterfly needles with metal needles, it was found that patients had less reaction to the plastic ones, so they're used routinely now. When can you not use the subcutaneous route? Well, I guess you do see patients from time to time who get quite a lot of edema. So it's like when they were developing the fentanyl patches. The trials that were done used the patches above the umbilicus because of the problems that some of the patients with advanced disease get with peripheral edema. You sort of worry about that. It's unusual to have patients who've got edema that sort of comes up past their shoulders. Having said that, we've got a patient in the unit at present who's dying from renal failure, not malignancy, and he's got edema up to his eyeballs, poor bugger. Subcutaneous infusion via a syringe driver is a very effective method of delivering the drug if the oral route is ineffective or unavailable. And I still can't explain why you can have a patient who's on an oral dose of morphine, that you convert that dose to a subcutaneous infusion of morphine and get much better pain relief. Now, obviously, that's to do with the levels of the parent drug and the drugs, how they're metabolized. But we see it again and again, a patient who's just not controlled on oral and they go on to a syringe drive. And that's why I guess we have a very low threshold of putting people on syringe drivers. And once again, it's not been an area that's been well researched or audited, and probably that's something that should be done. Spinal administration, with or without local anaesthetic or clonidine, usually requires specialist anaesthetic involvement. And we get a spinal put in probably, twice a year maybe. So we don't tend to use that very frequently at all. We had a patient recently who had really quite severe pain, a young lady with melanoma, and we tried a number of drugs, and eventually I said, listen, we're not winning here, and we got the anaesthetist down to see this lady, and the anaesthetist said, well, why don't we try some ketamine? And we did, because they're things that we can do ourselves, and it did actually help a bit. So her pain did improve a bit. And then she contacted the Royal Brisbane to look at putting in a spinal, and they were very happy to accept. I spoke to the Royal myself, and they were very happy to accept this lady. But by that stage, this lady had had enough, and she decided she wasn't going to have anything more done. And it was actually interesting after she'd made that decision, and we continued on. This lady was on a combination of opioids again. She was on oral methadone at the time, which was eventually changed to parenteral methadone, plus a hydromorphone pump, plus the ketamine that the anaesthetist started. She was on pretty industrial doses of all of this sort of stuff. But once she'd actually made that decision and come to terms with that and come to peace with that, she remained on a fairly steady dose until she died, which was only about 2 weeks ago now. But certainly, there's that option there for you well, I guess not for general practice, but you'd probably refer that patient to us, and then we'd refer that patient on if we were struggling. So there are options there in terms of delivering drugs and not going on and doing nerve blocks or something like that. So just some things to remind you when you're prescribing morphine. Just getting the dose right. So if you change from codeine or some other drug, maybe they've had a patch on that hasn't really worked, say a duragesic patch that hasn't really worked. It might be summer, the patch might be lifting up, or there might be a problem like that. You want to put them on something orally. So you're reasonably confident about the dose that you're prescribing, and you can look those doses up. There are tables. Do I need to prescribe a co-analgesic? And in that situation, you'd be thinking particularly about someone who might have either a neuropathic pain or a mixed pain picture with somatic and neuropathic pain together. Have you been good and prescribed a laxative, or at least spoken about laxatives to the patient? Do I need to prescribe an antiemetic? So under what circumstances would you prescribe an antiemetic? Certainly if they had nausea before, you'd be very, very keen, wouldn't you, to put them on a regular antiemetic. It is common. It said if you're starting someone de novo, it said somewhere between 20 and 30% will get nausea. So if you prescribe antiemetics to everybody, you're over-prescribing probably. It's known that women, for some reason, I don't know why, probably have about 10% more incidence of nausea with morphine than males. If you had, say, a female patient who'd had, some problems with nausea, not related to their drugs, or perhaps nausea related to codeine that they might have been on, and you're changing over to morphine, then I'd be thinking very much about giving that patient a regular antiemetic, and probably giving a prokinetic like metoclopramide up front. I think metoclopramide is a bit underrated as a drug. The problem with metoclopramide, of course, is it's got a short half-life. So sometimes people try and give it twice a day. It's not going to work twice a day. And the other thing is about dosing with metoclopramide. And people worry about getting, reactions to metoclopramide. And as I don't know whether I've told you before, in oncology we used to use megadoses of Maxilon, so 2 milligram per kilogram by 5 with platinum therapy before the advent of the 5-HT3 antagonists. But you could use a centrally acting drug like Stemetil, or haloperidol's the one that we use more frequently than Stemetil because it's tolerated. Haloperidol's well tolerated subcutaneously. Stemetil is not. Have I written out the drug regimen in sufficient detail? And I think it's important when you're starting people on something that's a bit new or a bit different. Just take 30 seconds to write it out. MS Contin, whatever, what it's for. It's a painkiller. You're taking it twice daily, and you can say, well, listen, you do need to take it 12 hours apart. You don't take it at 10 a.m. in the morning and then at 6 o'clock at night, because there's going to be gaps there.